Yes, sir. Perfect. Thank you.
Yeah, so I'll be presenting Exalt-3 trial where the first line Ensartinib was compared against Crizotinib, and this is an interim report. So patients included were those with 18 years of age or more, advanced or recurrent or metastatic non-small cell lung cancer, which are ALK positive, and those who had a measurable disease. Patients with asymptomatic brain metastasis and patients who received one line of chemotherapy were also included. So this is a global, open-label, multi-center phase 3 trial involving 120 centers across 21 countries, and patients were stratified also based on ECOG performance status, presence of brain metastasis, whether they received prior chemotherapy, and also geography. So the arms were the Ensartinib arm, where they were given 225 milligram of Ensartinib daily, and Crizotinib arm received 250 milligram BD. And the primary endpoint was progression-free survival in the intention to treat population, and the secondary endpoints were overall survival, time to CNS progression, and CNS response. And during the study, there was a protocol amendment which made the central confirmation of ALK positivity mandatory. So after that, the patients report after that were included in the modified ITT population, which is also analyzed separately. So from July 2016 to November 2018, 396 patients were screened and 290 were finally included in the study, 143 in the Ensartinib arm and 147 in the Crizotinib arm. These groups were arms were comparable with respect to all the important parameters, and important things are that around majority were never smokers, but even 40% were contributed by the current or former smokers. And brain metastasis at baseline was seen in 32% of the patients in the Ensartinib arm and 38% in the Crizotinib arm. And the previous chemotherapy was received by 34 patients in the Ensartinib, that is around 24%, and it was 28% in the Crizotinib arm, which is all comparable in both groups. So coming to the outcome, so this is an interim analysis. This is by the time of publication, around 119 PFS events for the primary endpoint had occurred, and it was around 62% of the 190 expected PFS event. So in the intention to treat population, that is including all the patients with ALK positivity, it was seen that median PFS was 25.8 months in the Ensartinib group, that is almost double that of the Crizotinib, where the PFS was 12.7 and the hazard ratio was 0.51. And in the modified ITT population, that is patients who had central confirmation of ALK positivity, was like there were 121 patients in the Ensartinib arm and 126 in the Crizotinib arm. The median PFS was not reached in the Ensartinib group, whereas it was 12.7 in the Crizotinib group. As evident from the curves, there was an early separation of the curves, and the 2-year PFS was 54% versus 36%, and hazard ratio for PFS is 0.45. And coming to the response rates, the overall response rate is also higher in the Ensartinib arm as expected, that is 75%, whereas it was 68% in the Crizotinib. Partial response was comparable in both groups, but the CR rate was almost double in the Ensartinib group, that is 14% versus 6%. And CNS response was also much higher, that is almost 3 times in the Ensartinib group, with 63% response rate, which is compared to the comparable to the other newer TKs. And this was 21% in the Crizotinib arm. And due to the small sample size, the subgroup analysis may not be statistically significant, but still this benefit was maintained across all the groups. And in certain subgroups like Asia Pacific region, there was the magnitude of benefit maybe more with the Ensartinib, which needs more studies to for a proper validation. And coming to the overall survival in the modified ITT population, it was not reached in both arms. So the overall survival could not be proven in this trial, and the 2-year OS was 78% in both arms, probably due to the use of other TKs following failure of Crizotinib. And with respect to the brain metastasis, as I've already told, around 30% had brain metastasis. And the patient without brain metastasis, the median PFS is not reached in the Ensartinib, and it was slightly higher compared to the other group in the Crizotinib, that's 16.6. Here also, Ensartinib was much superior, and with the hazard ratio 0.46. And the 3-year PFS was 61% in the Ensartinib group and 25% in the Crizotinib group. This is in those without brain metastasis. In patients with brain metastasis, that is around 30% of the study group, the median PFS is 11.5 months in the Ensartinib group and 7.5 months in the Crizotinib group, which is here also Ensartinib was superior. And coming to the PFS events, in the Ensartinib group, around 44% of the events were CNS related. whereas this was 61% in the Crizotinib group. And another important aspect was studied was that the development of brain metastasis while on treatment, which is a major problem in treatment of this group of patients. That is, it is only 4.2% in the Ensartinib arm, where it was almost 24% in the Crizotinib arm, again showing the superior CNS efficacy of Ensartinib. So coming to the safety, if you look at the graph, it's clear that Ensartinib has much more higher side effects, especially the rash. So it was almost 70%, where it was much less in the Crizotinib group. LFT abnormality is almost comparable. And the majority of the toxicity was not life-threatening or grade 3 or 4, but the incidence of rash and dermatological toxicity was definitely higher. With respect to serious adverse events, it was some sort of comparable: 11 patients in the Ensartinib arm and 9 patients in the Crizotinib arm. And 34 patients, that is 24% in the Ensartinib arm, required dose reductions, where it was 29 patients in the Crizotinib arm, that is around 20%. And discontinuation of drug has occurred in 10% of the patients on Ensartinib, where it was lower on the Crizotinib, that is 6%. So overall, there are some side effects like rash and dermatological toxicity is much higher in the Ensartinib. So all these results have shown the superior efficacy of Ensartinib, both in terms of systemic efficacy as well as the intracranial efficacy. And there is around 49% lower risk of progression or death compared to Crizotinib, which is comparable to the other second-line TKAs in this setting. And median PFS also is comparable. So, safety profile is rash and skin toxic profile are more, but other side effects of TKAs are lesser. And limitation includes an interim analysis, patients without central confirmation alpha are included, and OS data is immature. So it is definitely superior, but still there is no OS data. We do not know how to sequence these drugs, and side effect profile is slightly different, and there are much more side effects, and we do not know how they impact the quality of life, because they didn't report the quality of life outcomes. And in our practice, definitely access is an issue. Even Crizotinib is not accessible to our majority, and postulator issues also will be there before this influence our practice. Thank you.
Thank you so much, sir. For next talk, I would like to invite Dr. Suresh Babu, who is a medical oncologist, currently working as a consultant in Kidwai Medical Center in Bangalore. To you, sir, now.
Thank you. Thank you. Can I share my slides? Am I audible?
Yes, sir. So your screen is not visible.